All right, good afternoon, everyone. Sorry. This is a combined event, so for those of you in the room who are here that are residents, I have a couple updates from Resident Council to give you all before our talk. Just FYI, for those of you who don't already know who the 2018-19 officers are, I'm Dom Gattosi, I'm the president. Then we have everyone else listed there. These are also available if you ever have any questions regarding specific issues on those topics. You can contact the various vice presidents. You're also always welcome to email me with any questions. Voting, GME is really trying to help get residents keeping a voice in their civic duties. So if you want to vote, that's how to register. This was sent out an email this morning by Phil on behalf of Dr. Unruh. There are also forms in Andrea's office. If you're already registered and don't know how to absentee vote, there's also information on that so that you can also vote even though you have clinical duties that keep you here. Transfer Center, for those of you guys who haven't already heard, the 89999 extension will now keep you on hold forever. So these are the direct lines that'll get you someone who will immediately give you the information regarding your transfer coming in, name, date of birth, MRN, whatever you need to get admit orders or get images sent. And then meal card money, we've heard that there's not a lot of support for the new system. In September, we're going to review the usage and how it's appropriated and to go from there. And please come to any resident council meetings first Mondays of any even numbered month. So the next one will be first Monday of October, I believe the 1st. You'll get more information on that there, and you can ask any questions. The officers are all there and you can express your opinions and questions. All right, without further ado, I'll get Dr. Barron here to introduce our speaker for today.
Great, thanks. So, for those of you who don't recognize me, I'm Sheriff Rick Barron, the Vice Chancellor of Research, the Sheriff of Research, right, Yolanda? That's right. So this is so exciting today to be able to do a combined program with our Research and Discovery Grand Rounds and the resident group. We did so the surgeons have their resident meeting in the morning at 6:30. And so I came for that, and Dr. Bhat did too. And then the internist and other non-surgical specialties have traditionally their event at noon. So it worked out that we can combine it with R&D. And it's really a pleasure today to have Dr. Anand Bhat give you a presentation on health systems around the world. And I first heard Dr. Bhat give this talk a few months ago when a friend of mine sent me an email. It's actually, many of you know Josh Freeman, who's no longer here. He's now retired in Arizona. But I got it from Josh Freeman, who follows healthcare issues. And so I went to hear Dr. Bhat talk at the Westport Public Library. And there was only a few doctors in the room. Most of it was the public. But it was a fascinating talk. And I thought it was a really balanced approach that Dr. Bhat explains the different healthcare system models globally. And I think it's fairly non-biased, although you can make up your own minds. And I've been trying to find opportunities for Dr. Bhat to give this talk here at KU before he leaves our KU family. So oddly, by weird coincidence, after I heard him give this talk in Westport Public Library, I found out that he is currently a sleep fellow at KU Medical Center. Oh no. And then sort of to go back in time, but before he was a sleep fellow, he's a native of Texas, and he went to Austin for undergrad, and then he went to Galveston for med school, and then he went to Cleveland, Case Western, for his internal medicine residency. And then he came here for sleep. But between somewhere in there between undergrad and Galveston, he spent a year getting a master's degree in London at the London School of Hygiene and Tropical Medicine. So he got a master's in health policy. So Dr. Bhat tells me even before he did that, he was interested in some of these concepts, but I think that really gave him the opportunity to dig very deep into how we deliver medicine globally in the world. And so he is really part of the national and international conversation about healthcare moving forward. So he's been sort of a gem here at KU for the last year doing a sleep fellowship, and I just wanted to take advantage of all of his knowledge before he and his wife move to Ann Arbor next month. So without any delay, then Dr. Bhat, come on up. And I'm going to do something that's been traditional at R&D Grand Rounds, not at the resident lecture. So the residents can probably tell this is more fun than R&D Grand Rounds is more fun than your resident lectures. So because I am the I'm the head research officer at KU, i.e. Sheriff Rick, every time someone gives a talk on our research and discovery grand rounds, I deputize them. So a few in the room have been deputized. Dr. Wolf has and others. So you didn't know this is coming, Dr. Bhat, but you are now officially deputized. So
Deputy Jayhawk.
You're Deputy Jayhawk. All right. There's the mic.
All right.
Thank
Great.
You
Well, thanks, Dr. Barron, for allowing me this opportunity to talk to this audience here. I have given this talk in Cleveland and once here at the Kansas City Library for the community, because I think we're not going to have healthcare reform unless we have a more educated public, and you're not going to learn anything on TV or reading the news about healthcare. So I just want to just give a facts-based approach. What exactly is there in the world, what we do, what we don't do, and what the rest of the world does. And from there, hopefully you'll have a skeleton of knowledge from which you can add different facts to it. But I think this will be the basics you need to know. And now when you talk to other people or meet someone from another country and talk to them about their healthcare system, you'd be more or less able to guess what kind of system they have and how it relates to us. Also, I went to med school in Texas. We were very active in physician lobbying and activism and advocacy in Texas, maybe because we have the worst healthcare system in the country, I don't know. But that's really where I cut my teeth learning about these things and went on to study it later on. So I don't know that other states get that level of education. I didn't see it in Ohio. I don't know about here. But hopefully this will be able to improve your knowledge. We're also having a talk on December 4th from a health economist. I put it at the end. He's coming from University of Massachusetts. He'll be talking more about the economics of Medicare for all. If you are interested, email me and I'll get you on the email list to be involved in that event. So anyway, this is health systems around the world, or my funny title is How Foreigners Do It. Put the Eiffel Tower. So, okay, so the objectives, how to categorize healthcare systems around the world, how the United States compares and contrasts these different healthcare systems, and how the United States developed its healthcare system. So pretty simple, right? You can do that in 40 minutes. All right, so what's wrong with American healthcare? Everybody says something's wrong, nobody can tell you what it is. Well, it's simple. We spend a lot on healthcare, both absolutely, dollars per person, or by percentage of GDP. The United States spends 17.4% of its GDP on healthcare. That's not normal. The OECD average is 9.5%. So we're spending almost double what every other country is spending. OECD is the organization of, I don't know what it stands for. It's basically all the developed countries. And you can see here, it includes the United States all the way down to, say, Italy, Greece, and then some middle income countries like Mexico and Turkey. So the United States is not spending a proportionate amount compared to other countries in the industrialized world. But the other thing is the outcomes aren't good. So life expectancy is the easiest way to measure how good your healthcare system's working. The United States spends more and gets less. So if you look at countries, generally the more you spend, the better you do. But once you get past about $4,000 per person, doesn't really add up that much. It helps a little bit. But then the United States is off the charts here at $8,000 per person in 2011, and the life expectancy is significantly below that curve. That's a regression analysis there. Then you talk about rankings. How's the United States doing in the rankings? Well, the WHO ranking was 37th in 2000, not very good. If you can have a whole lecture about the WHO ranking, but I'm not going to talk about that. Then there's the Commonwealth Fund. This says 2010, but also in 2017, they did a ranking. 11 countries, United States, Netherlands, Australia, Germany. The United States came 11th out of 11 countries. So we're not doing too great. So, okay, well, let's start at the basics. Let's start really basic. Let's not talk about today. Let's talk about the past. So in the past, we paid for healthcare out of pocket. Doesn't matter what society you were in the world, doesn't matter what country where you were, whether you went to a witch doctor in Africa, Ayurvedic doctor in India, or curandera in Mexico, you paid out of pocket, okay? So that's how most medical care is funded. And in most developing countries, which is most countries in the world, still a majority of your healthcare spending is coming out of your pocket. It's coming out in dollars, rupees, chickens, whatever you have, you pay out of your pocket. Now, generally, as a country develops and gets richer, the percentage of the healthcare spending that comes out of your pocket will fall. And you can see that as private insurance and government funding for healthcare begins to increase. So this is a chart here of out-of-pocket spending, and you can see poor countries. You have Myanmar or Burma, India, Nigeria. You're looking at over 75% of the healthcare spending is out of pocket. Okay, there's no insurance, there's no government health spending. You're talking about the vast majority of spending is coming out of your pocket. And then you can look at a middle-income country like Mexico. You get 51%. So about half is coming out of your pocket, which is less than in India or other countries. Then in the United States, we pay a lot of copays. I'm sure everyone here has paid one. They're terrible, but they're actually only 15% of the healthcare spending, which is kind of crazy. 85% is paid by insurance or government funding. Then the United Kingdom, they only have 3% out of pocket. They have some strict rules about the copays. Now, why is out of pocket wrong? Well, it's a regressive tax if you look at it. Whether you're looking at your driver's license, parking ticket, or any other flat tax, it is a tax which will take a higher proportion of your salary the less money you make. So a $100 copay, if you earn $10,000, costs a lot more than if you make $100,000 a year. So it's a regressive tax. So it hurts. It's a reverse income distribution from rich to poor. Then it will reduce those who seek care. This is another one. If you are sick, I mean, I'm sure anyone in this room may have needed an ER visit, but they're scared to go because of the copay. They don't know what they have, but they can't go because they're afraid of it. The problem is we're physicians and we have this issue. Imagine the general public. This reduces people who will seek care, and people in general cannot tell what is necessary and what is unnecessary care. They don't know. I mean, half the reason you see your patients in medicine is for reassurance, really. So you can't get that reassuring care because you're afraid to do it. And then you avoid seeing the doctor when you need to, and that leads to avoidable or preventable death and disease. So that's another reason why out-of-pocket is a bad idea. The only country which is industrialized, which is high income, is Singapore, that uses out-of-pocket spending. And that is because they copied this idea from Stanford. I'm not sure, I don't know if it was the Hoover Institute or not, but they copied this idea from Stanford, and they switched to this out-of-pocket model with medical savings accounts. Everybody gets money taken out of their paycheck, put into a medical savings account, but then you just pay out-of-pocket using that medical savings account to pay for your health care. It's the only developed country that uses out-of-pocket still. There are some small insurances, MediShield and MediFund for older people and for poor people to help them out, but generally the MediSave is the main healthcare system in Singapore. Okay, then the question will be, well, Dr. Bhat, why do we have insurance? Well, why do you have insurance? Anybody ever asked yourself why you have insurance? All of you buy insurance. You have Geico, you have Allstate, you have home insurance, you have car insurance. Why do you have insurance? Like, what's the point? So insurance is a process, and this is not just for healthcare. It's a process by which everyone pays an equal amount towards a large pool of money, and those who need that pool of money will withdraw money from that pool when they need it. So you're not going to have a car accident this year, but you may in the future. So everybody in this room pays into, say, Geico, and then, you know, some people will have the accident and then they all get the money. Some people won't, and they'll just keep paying in. And that's the simple concept of insurance. So we have pooling of resources. So all of us here work for KU. So all of us are in a pool of an insurance money. All our money goes together to form the KU Medical Center insurance pool of money. Then we're all paying, it's equitable because we have equity. We all paying the same premium, whatever it is, $150 a month or whatever it is. Then the other advantage is we're prepaying the money. We're paying the money now, so when you need the insurance, it's there for us. So you don't have to worry about coming up with the money when you have that reason to use the insurance. Then the other important reason is financial protection. We have insurance to financially protect us, which I don't think anyone in the American healthcare system realizes. The insurance is supposed to prevent us from going bankrupt. But that's why you do it for any insurance, whether it's your homeowners or car insurance. It's for financial protection. So with that in mind, we're going to talk about the first healthcare system in the world, which was in Germany. This is about Otto von Bismarck. If you think back to 10th grade, at least my 10th grade, Otto von Bismarck was the first chancellor of Germany. Chancellor is like prime minister in Germany. So when he was the first chancellor of Germany, Germany was not a country until he was chancellor. It was a bunch of little countries that they combined into one country. So it's only been a country since like 1870 or 1875. It's younger than the United States, actually. So when he combined the countries into one under the Kaiser, he created social health insurance. Social health insurance is what we call the Bismarck model. And a couple other countries have this, France, Belgium, the Netherlands, Japan. Many countries have this model. So what is it? It's a payroll tax. It's quite simply, it's a payroll tax. It's a tax that you pay as an employee and your employer pays some as well. Now, this is how, it's kind of like a Social Security tax or the Medicare tax you pay every paycheck. So you have a free choice of physician. You have a free choice of insurance today in Germany. Traditionally, and in some countries, you don't have a choice. You're limited by your occupation or by the state you live in. Like I said, Germany has many states because it wasn't one country until recently. And you're allowed to choose your insurance. There's lots of insurance companies there, which are called social health insurances. If you're unemployed, the government will pay your premium. That's another important fact. And the other thing is that there's no funding from taxation, from general taxation. So if you guys go to Germany and, I don't know, drink a bunch of beer in Munich, none of the money you spent went to anybody's healthcare in Germany because it's only from employees and their employers. That's it. It's a payroll tax. All the money in Germany spent for healthcare has come out of either your employer or your employee, or if you're retired, it comes out of your pension. The social health insurance model, the health benefits are defined by law. They're uniform. They're pretty much the same. Doesn't really matter which sickness fund you use. That's another word for the social health insurance, sickness fund. They're pretty much the same, very little difference between them. Benefits are the same, prices are standardized. They don't vary even though there's multiple insurances. The physicians in the hospitals are private. And the only other interesting thing, which Germany has, but France and other countries may not don't have, is 10% of the population buys private health insurance. It tends to be government workers and the high-income people. So I don't know if you've been following the election. There's all these people on CNN, they're talking, and they say single payer, single payer. I don't know if you've heard that word this year. So is Germany a single payer system? I would say no, it's not. It's a multi-payer because there's multiple insurances. And now traditionally you have defined benefits and prices. The prices are all uniform, doesn't matter which insurance you have. Your benefits are the same, doesn't matter which insurance you have. And it's co-managed between you and your union, and your employer and your union. So maybe the resident council would be negotiating, and I don't know, in Germany. There are some co-payments. It's not totally free at the point of service. And sickness funds cover unemployment, workers' comp, and dependents. So this would have meant a man in 1883, he would have gotten coverage, cover his wife, cover his children. That's why not everybody had to work in the family to get the healthcare insurance. So the interesting thing about this is when Bismarck introduced this was originally the workers' comp program. It was workers' comp plus healthcare. But they didn't, healthcare was just this thing they threw in. It wasn't the most important part. It ended up being healthcare was the most important part over time, but at the time, this was just supposed to be the workers' comp program. So I have some sample prices here from some different Bismarck countries. You have 10 euros to see the general practitioner in Germany. That's once every 3 months. So if you see them multiple times in 3 months, you don't have to pay a second time. Then you have see an orthopedic doctor, 26 euros in France. Then you get reimbursed from your insurance, and it's down to 8 euros. In Japan, you can get an MRI for $105, which is cool, 11,400 yen. So cheap MRIs in Japan. And then just to give you an idea of the tax rates, it's about 8.2% from the employee and 7.3% from your employer, or if you retire, your pension. So that's roughly how much you're paying. Now the other one, the next model that's very interesting is called the beverage model. This is a common model you'll see in many countries. And I call this the story of the miner and the aristocrat, because you had a gentleman, Lord Beveridge, who was a PhD in economics at the London School of Economics, and he wrote a report during World War II about how the healthcare system should be rebuilt after World War II in Britain. And it was implemented by the first Labor government after World War II. If you compare it to America, you could say, well, the United States had the New Deal in the 1930s, all these reforms during the Great Depression. Britain didn't really have that because it was busy getting blown up during World War II. So after World War II, they had to come up with all the social programs that we had in the 30s. So the first Labor government, Aneurin Bevan, who was a Welsh miner, was the health minister and introduced the National Health Service. And it's been copied by many countries around the world. Now, this is socialized medicine, in my opinion. When people say socialized medicine, it's a big scare word. This is socialized medicine. You know, I'm giving you the definition. I consider this to be socialized medicine. Why? Because the government owns the means of production in healthcare. So that means it owns the hospitals, it owns it employs the physicians, all the specialists. And since this is a medical audience, I could change this a little bit. Specifically in Britain, all specialists, endocrinologists, rheumatologists, anything like that, they are salaried. They work for a hospital. You can't have an independent clinic if you're a specialist. So you have to be employed by a hospital and be referred to them. The general practitioners, it's a little different. So this is general taxation. So all the money can come from whatever tax. Could come from sales tax, could come from capital gains tax, property tax, whatever the tax system is. The general tax system funds the healthcare system. So some of you guys may be flying to London and buying a Prince Harry mug or something like that. You're just so excited about the royal wedding. So did you contribute to the British healthcare system? Yes, you did. If you paid sales tax, some of that money could have gone to the healthcare system. There are no bills. And actually, legally, bills don't exist, actually, because there's no insurance. It's just done. It's a service, like a fire service. You don't know how much the fire call costs. You don't know how much the police call costs. It's a service. That's why it's called National Health Service, not National Health Insurance. So there are copays for drugs and glasses, but they're capped at like 15 or 16 pounds. So because the government is funding everything, you as a taxpayer don't want to be spending a lot of money on this. So you will want the most cheapest cost-effective healthcare system in the world. And this is where the British really lead the way on this. So that means, what does that mean? It means general practice, or which is what they call primary care, is the cornerstone of the entire health system. Can't waste money going to referrals, can't waste money on specialists. So when you go, you have to be registered with the general practitioner. So when I was staying at a London School of Economics dorm, and before I landed, I was told that I needed to register with the general practitioner affiliated with my dorm, which is affiliated with London School of Economics. So I registered with the general practitioner. So I knew who my doctor was before I had even moved there. It was crazy. If I needed to see a specialist, the general practitioner would have to refer me. It's totally like closed off that way. Like general practitioners, they're independent. They're not owned by the government. They own their own practices. They actually, I would say, probably do much better than family doctors here on average. They probably make like £150,000, which is like time and a half here. So you're talking like $200,000 really. I mean, they don't do bad at all. I would say that's probably the big salary difference between here and there. The specialists, I think, probably make less than here for sure. There's a global budget, meaning there's one pot of money. This is the healthcare spending. It's decided, and they write the budget, and that's it. And there is rationalizing and rationing of healthcare using the National Institute for Clinical Effectiveness. This started under the Tony Blair government in the late 90s. They basically have to decide what they want to spend their money on, what they can't. Because the government is paying for it and you're the taxpayer, you're going to have to decide what's effective and what's worth spending on. And morally, the way they have philosophically decided, they've decided spending money on a 5-year-old versus an 80-year-old is supposed to be ethically the same. So but you have to keep in mind, they have a cutoff of 6 months life expectancy for, I think, 30,000 pounds of spending. And that's how they determine whether to approve a procedure or not. And if it's approved, then all the local health authorities have to approve it. That's roughly how it works. It gets even more complicated, but that's all probably you need to know at this point. Then the next healthcare system is Canada's, the National Health Insurance model. Now, this guy was a preacher, I don't know if any of you guys watch TV. There's the guy in 24, Kiefer Sutherland. This is his grandfather. It's really weird. So his grandfather was a premier, which is what you would call the, I guess, the governor of Saskatchewan. It's like the Kansas of Canada, I guess. It's like kind of rural and stuff. So he's a Baptist preacher. I think he was from Scotland originally. And he got elected in the 30s or 40s to be premier. And he started the healthcare system, which was an insurance system. And then it was just hospital bills, went up to all bills in 61. Then the national government sort of copied it for the whole country. And so you can say the Canadian healthcare system kind of started in the 1970s. If I'm not mistaken, it happened under Pierre Trudeau, who is the father of the current prime minister. Taiwan has the same healthcare system, and South Korea does too. So Canada, so that word, back to what you hear on the news, people will say single payer, single payer. What is single payer? So I'd say this is single payer. Why? Because there's only one insurance. It's the government, and it's called Medicare. So one government-owned health insurance, but all the rest of the health system is private. So you have private hospitals, private providers, physician-owned practices. There are no outpatient or inpatient bills. That's one of the rules. You cannot be charged for a hospital visit, can't be charged for any outpatient visit. I don't think you get charged for labs either. And the other thing is this is sort of the system is run differently depending what province you're in. So the federal government sort of coordinates funding, but it doesn't run the healthcare system. Each province runs their healthcare system differently. So what's covered in Ontario may be different than Quebec, which may be different from another place. But there's a few rules, like no bills, has to be run by the government, has to be an insurance, but the provinces run it themselves. So the question would be, is there private insurance? Well, yeah, there is, but it can't cover what Medicare covers. Okay, so if you need, the example I gave this morning was cholecystitis, okay? If you had private insurance and you had a Medicare insurance there in Canada, if that may incentivize you as a surgeon to say, well, I'll schedule the guy with the private insurance first ahead of the guy with the Medicare. So Canada doesn't want that problem. So they say, no, you can't cover cholecystitis as private insurance. You can only cover what the government doesn't cover. So that means, so that avoids the two-tier system. So if you buy private health insurance in Canada, it's only for paying stuff that the government doesn't pay for. So outpatient drugs, they don't have outpatient drugs covered in Canada. I think glasses maybe, and private rooms, and some other benefits, but it does not duplicate anything the public system does.
Can you go back to explain how then the physicians get paid in Canada?
So that would be more fee for service, like here. Yeah,
So
yeah.
Private doctors.
Yes, yes, they are private doctors. I know, I talked to somebody in Quebec, and I think the province may own some clinics, but you can, like, just like you'd have a, I don't know.
Most of my friends that practice in Canada, that they, whether or not they're at a university or not, they function as private doctors, and they turn their bills in to the government, to Medicare, and they get paid.
Yes.
That's how they do it.
Yeah, yeah, yeah. So you're not an employee of the government in Canada. You just bill the government. So that's the big difference between the UK and Canada. So again, I'm just going to go over private health insurance in the world. So does private health insurance exist in these different countries? Yes, but it means different things. So you have complementary health insurance or co-insurance, which would pay your co-pays. That's what you have in France. That's what people in America do who have Medicare. Older people, they buy a little private complementary thing. That's to pay their 20% co-pay. So they have that in France. Supplementary is what I was saying in Canada. It just pays what the public insurance doesn't cover. Comprehensive is less common. You see that for that 10% of the population in Germany that has to buy private health insurance. The only another healthcare system which is important to talk about, which is weirdly similar to the United States because it is unique on its reliance on private health insurance, is Switzerland. Now, Switzerland's kind of an interesting country. Switzerland has cantons, not states, cantons, but they're like the size of counties. And Switzerland has many languages and many religions, Catholics and Protestants. They speak English, German, French, and Italian, depending where you are. So it's their constitution actually is modeled on the U.S. Constitution. They have a Senate too, which is like 2 per state and stuff like that. So it is very similar in terms of politically structured and federalism. So their current healthcare system began in '96, and it is the second most expensive healthcare system in the world. Generally, it depends who you're looking at. I was looking at the OECD data last night, and based on their data, they were saying the United States was $10,000 per person on for healthcare. Switzerland was like $8,000, so like 20% cheaper. So now you're going to see some words you may have heard in the U.S. You've heard the word individual mandate, open enrollment. You hear about how individual mandates means you have to buy health insurance. That's the goal. You have to buy health insurance. If you don't, the government will buy it for you and then just take it out of your taxes. You have open enrollment. You can sign up for whichever health insurance you want. There's a basic package which is not sold at profit. The basic package everyone has to buy. The private insurance company's goal is to get you to buy a supplemental or an extra, which they can sell for profit. So that's kind of how they get away with it. But the basic coverage is not sold at profit. If you're lower income, the government will, the cantons, the local governments, they will subsidize purchase of your health insurance. So again, kind of like that Obamacare tax break to help you pay if your income's not high enough. So the difference, though, is the benefits are totally standardized. Everybody pays the same premium for the same policy, and it's a fixed schedule of deductibles versus premiums. So there's like 4 of them, and it's like, do you want more premium, or do you want more with less deductible, or do you want more deductible with less premium? And there's like 4 combinations. There are copays. The copays are capped, though, at 700 Swiss francs, which is 700, which more or less $700, more or less. So we have copays, but they're not capped at $700 here. And then you have consumer choice. This is the most consumer-oriented healthcare system in the developed world, except for maybe Singapore. If you're interested in developing countries, it's a whole other topic. You can spend your whole life studying these. Just a quick one about most effective healthcare systems for spending. The Rockefeller Center in 1985 said that China, Costa Rica, the Indian state of Kerala, and Sri Lanka had the best healthcare systems for the amount of spending they had. Then 25 years later, they looked into who were the next good models. Thailand, Kyrgyzstan, Tamil Nadu, which is a state in India, Bangladesh, and Ethiopia also did very well for their level of development and healthcare spending. So now I get to the question. So this is Texas Medical Center because I'm from Texas, wanted to show that. What healthcare system out of all the ones I showed you here is the United States? I mean, come on, you guys can answer better than the surgeons this morning. All of them, yeah, great. Yep, you answered it. We're all of them. If you go to the VA, it's British. If you have health insurance from your employer, then it's kind of like Germany and France. If you're on Medicare, it's like Canada. If you have medical savings accounts, it's kind of like Singapore. If you don't have insurance, you're like any other developing country. Just out of pocket, buddy. So what are the problems with the American healthcare system? The number one problem, the 2 main problems are administrative costs and prices. These are uniquely high in the US. So some people will tell you, you go to any private practice doctor's lounge in a hospital and people are like, these people use too much, you hear that. So actually, no, if you look at the OECD data, it's not that remarkable, our usage. So our doctors' visits per capita, if you look, the OECD average is 5.9, the US is 5.8, so a little bit below. And say Canada, our neighbor, is 6.4. So they see the doctor more often. Look at the check. They see like 12 times a year. They just love the doctor. Doctors per 2,000, actually we have less per 1,000 people, 2.8 versus 3.1. Nurses, we seem to have more nurses. Maybe they're billing, I don't know. Yeah, I don't know. There was a thing. It was in The Economist, which is they're kind of snooty. They said Southern Europeans use more healthcare. I don't know if Hungary counts. Maybe it's like a Catholic versus Protestant thing. I don't know, but I know Italians and Spanish and French do use more prescriptions than Northern Europe. The number of beds per 1,000 people is lower than the average in the US, 3.8 versus 3. Admissions per 1,000 people is less than the US. Average hospital stay, this is from 2000, so this number's got to be lower with hospitalists taking over that field, versus 6.4. Days per capita, it's lower in the US. The one thing that really stands out is MRI usage in the US. That's the only thing that's really high. Apparently, though, they have a lot of MRIs in Switzerland, and they love them in Japan, 23 per million. But I guess it's $100, so who cares? CAT scans, we have a little bit more than average, 13.6 versus 12.2. Then dialysis, which is like a whole other topic. I don't really want to talk about that, but they do have a lot of dialysis in Japan. Okay, so then the question becomes, well, Dr. Bhat, why are we spending more for less? It doesn't make sense, right? Well, if politics was about facts, it would be a different situation. But it's not. So healthcare markets are monopolies. This is your first lecture in healthcare economics. Healthcare is not a normal market. Why? Because it's a monopoly. Everything's a monopoly. If you have a prescription drug that's FDA approved, that's a government monopoly. If you have a hospital, you're licensed by the state, that's a monopoly. If you're a physician, you have to go to medical school, finish your residency, and get a license from the state. If you're a nurse, same thing, license from the state. Every single element of that is a monopoly. You can't just become a witch doctor and charge to be a doctor. You can't just create a hospital in your backyard. You can't do that. People do that in India, but that's not developed countries. You can't do that. So that's a monopoly. Then competition doesn't meaningfully exist. Now, I can make this statement very clear in this area. I mean, between here and Denver, I don't think there's probably much hospital competition happening. You'd be lucky if you have one hospital, and same thing from here to St. Louis. I'm sure most towns, rarely you'd find more than one hospital in any town that's not in Kansas City or St. Louis. Columbia has 2 hospitals? Okay, but pretty rare. And then in terms of emergencies, it becomes less so, because if you're talking about trauma services or things like that, you're not shopping for doctors after you got shot or you break your hip. You just want to go to the first hospital. So there's no competition. It's not meaningful there. Monopolies lead to higher prices. That's well known. Then private health insurance in general, in any country, not just the US, has a higher amount of administrative costs than public health insurance. So United States, Medicare spends 2.2% on administration. Private health insurance, it's about 10 to 15%. If you're looking at Medicare Advantages, I think it's like 11%, which is the Medicare delivered by private health insurance. And so what does that mean? For-profit insurance companies reduce the money that's actually spent on healthcare. So that $150 a month you spend on your Blue Cross Blue Shield of Kansas City, or no, it's Kansas, right? Whatever we have. That money you spend, some money is being sponsored, the royals, and spent on advertising, spent on a CEO who may get $4 million. The head of Medicare makes like $300,000 or $400,000. That's it. So there's no marketing, there's no glossy ads, there's no billboards for Medicare. I've never seen Medicare sponsored the Cleveland Browns. It just doesn't happen. So that's money that's not going to healthcare. No dividends from Medicare. So that's money that's not going to healthcare. Yes?
Just wondering, so the higher prices aren't because of this overhead that they're covering?
No, I'm going to get to that. So naturally, healthcare is a monopoly in any country. That's not unique to the US. But when you have monopoly supply power, a government or healthcare system responds with monopoly buying power. This is called monopsony power. This is where you negotiate the price to respond to the fact that, say, Lipitor is a patented medication, and there's no other Lipitor, so you have to negotiate because it's not a market. Competition is not going to reduce the price of a patented medication. So you respond to that with monopsony buying power. Even in multi-payer healthcare systems like Japan and Germany have a negotiation where they set the prices at the beginning of the year. So it's a meeting between the healthcare ministry, the medical association, and the hospital association, and they set the prices. And this is going to be the price of the MRI, whether you're in Tokyo or Sapporo or Niigata. This is the price, and it's all fixed at the beginning of the year. So the United States has a multi-payer system, but there's no standardized pricing, which even in multi-payer systems, you just don't see that. Medicare by law under the George W. Bush administration is forbidden to negotiate drug prices, but the VA has always been able to negotiate drug prices, and they spend like 40 or 50% less for drugs than Medicare does. So we have systems, but no system, basically. The VA started in the 20s. After World War I, employer-sponsored health insurance started in the 1940s. Medicare and Medicaid started in the 1960s. CHIP started in the 1990s. And Obamacare started in 2010. So like, who made this? Who designed this healthcare system? Well, actually, until Obamacare, nobody designed it at all. It's a complete accident. Now, the reason you have all these accidents is because it is evolved by accident by the defeat of comprehensive healthcare reform over the decades. So they would try healthcare reform overall, a major healthcare reform. It would fail. Then they'd come up with a partial solution, like, oh, let's just cover the veterans, okay? Let's just cover the kids with CHIP, okay? That was supposed to be a temporary thing until we do real healthcare reform. We never do real healthcare reform, and then that becomes a protected public. And that partial group, well, we have Medicare just for old people. Yeah, we'll add everyone else later. No, that never happens. So you have these protected publics. Now, if you had a situation where veterans, old people, children, poor people, none of them were covered, then you might have a political majority willing to do something about it. But you have these little partially protected publics. That means the people who are not without health insurance are actually sort of like lower middle class, but not very the poorest. So it's this like weird range maybe of like the poorest, like, you know, it's sort of the middle income. It's not the absolute poorest, and it's not children or people you can make sad movies about. So you see, so that's part of the problem. The other issue is the United States has a Congress. Congress is not very popular. They don't do much. They do less than when I wrote this talk 4 years ago. They have in Congress, compared to a parliamentary system, it's very difficult to pass laws. Obamacare went through 3 different committees. You have an upper house and lower house, which a lot of countries don't have. That makes it twice as hard. And then it's just harder to pass legislation in a Congress system or compared to a parliamentary system. It's much easier because you can't be prime minister unless you have a majority in parliament. You can be president and not have a majority in Congress. And even when Obama had a majority in Congress in 2009, 2010, they didn't really sort of get along, and there was all these changes that were made. So the people who failed before, we have the progressive era, health reform era. That was going to be on the German model. They were going to do the German healthcare system in the 1910s. Then that failed. Then Harry Truman, local guy, he tried to do national health insurance, and then he failed. The AMA went crazy about that one. They spent a lot of money to try to stop his reelection in '48. Then Nixon, they say Nixon was probably the closest to getting healthcare reform, but it just didn't happen, and Watergate happened, so it never happened then. Then the Clinton program was not called Hillary Care. It was technically manage competition within a budget. It's very complex and probably not worth knowing, but that's the plan. So every decade when they do healthcare reform, every reform plan had different supporters, different opponents, different philosophies, why people were supporting what. And the American Medical Association, which was very powerful from at least 1900 up to about 1970, opposed healthcare reform all of those years except for in the 1910s and then in 2010 with Obamacare. So, okay, why do you, physician, have employer-sponsored health insurance? You might want to know. Well, it's an accident. The accident was World War II. During World War II, there was no unemployment. Why? Because everybody was either overseas fighting Germans and Japanese, or they were here working in factories to make equipment to fight Germans and Japanese people. So there was no unemployment. What does that mean? There was crazy salary inflation, and inflation was through the roof. So the government created price controls. And price controls meant that if you wanted to go from Ford to GM, or if you wanted to switch from this steel mill to that steel mill, they couldn't offer you a raise because it would just cost too much price inflation. So people threw in this idea, say GM said, well, why don't you switch to me from Ford? I will give you health insurance. Which was not subject to the price controls. It was a complete accident, and they just did it because they had no other way to lure other employees. So they just sort of threw the health insurance, and it just became this default that you got your health insurance from your employer. It was just a complete accident. In the 1950s, which made the system continue, the IRS changed its rules and made your employer spending on health insurance tax deductible. So it's a huge subsidy. It's very inefficient, and that's why you get your health insurance from your employer. The other thing that's weird about the United States is the United States got Social Security before it got health insurance. Most countries got health insurance first and then developed Social Security. So that's why we have Medicare, which is technically an amendment to the Social Security Act. So this is the only country in the world that has a healthcare system for old people. That's it. Do you know any country in the world that says, oh, we have this insurance, it's only for old people? That's it. No, it doesn't exist because it was an amendment to the Social Security Act. Other thing that's also very weird is Medicaid. Why was Medicaid created in the same legislation but separated from Medicare? Well, it has to do with racism. Well, in 1965, Lyndon Johnson was president, and the Southern Democrats were a large caucus in the United States Congress, and Wilbur Mills, I believe his name was head of Ways and Means. He was from Arkansas. He did not want black people to get the same health care as old people. And so he deliberately separated Medicaid from Medicare. Medicare is a purely federal program. Medicaid is a state federal program. So it depends what state you're in, what you cover. I mean, if we talk about sleep medicine, I can't get a sleep study on Kansas Medicaid, but I can get on Missouri Medicaid, for example. If you're in New York State, they have very generous Medicaid, but other states don't. So it was deliberately separated and always designed to be an inferior program because of racism. So now, why can't we talk about healthcare like adults? But I mean, now I don't think anybody can talk like an adult anymore. The whole country's gone crazy. So once upon a time, somebody said, one of these days, you and I are going to spend our sunset years telling our children and our children's children what was once like in America when men were free. Somebody said this about Medicare. Does anyone know here? The faculty should know. No, nobody knows? It is actor and future governor and president Ronald Reagan campaigned across the country telling everyone, if we develop Medicare, we would lose all freedom. So it's a long-standing thing. It didn't start with death panels and whatever, stuff like that. People have been crazy about healthcare here for a long time. Another thing is a foreign element to it. When they were trying first healthcare reform, which was the German system that they wanted to have, people said, well, that's like the Kaiser's plot against America. And you guys are just, it was like a World War I thing. So that's why part of the reason it failed. Then when the Soviet Union, people said it was a communist idea. We can't have it because it's a communist idea. Then the AMA created that socialized medicine hysteria against Harry Truman in 1948. So that's a buzzword that nobody really can define in a meaningful way. There was a campaign against Medicare with Ronald Reagan and other people. The other issue is non-bipartisan healthcare voting. A lot of those health reforms that were passed in the past had bipartisan support. If not a majority of the other party, at least a minority of that party did. But since George W. Bush, a majority of all the healthcare votes are either 100% Republican and 0 Democrats, or 100% Democrats and 0 Republicans. That wasn't true when Medicare and Medicaid passed. That wasn't true when a lot of the healthcare reforms were passed. And that's why you have the situation, if the president changes, they just try to throw out the whole healthcare system. It's because the other party has no and never supported it in any way, didn't contribute it to it in any way. So then there's the Affordable Care Act, which I don't want to talk about, but generally you guys can get the idea of all these healthcare systems. Obamacare did not, basically made all those systems bigger. If you have employer-sponsored health insurance, it made it bigger, made Medicaid bigger, made Medicare bigger. It just basically increased the currently existing plans. It was called, I believe the technical term was minimally invasive healthcare reform. So to keep all those programs in line, even though it doesn't make sense, and just reform just a little bit on the side. So actually, it's quite conservative in terms of if you look at what it is, what it should be. It was very, very conservative and just minimally tweaked with all those 4 major programs. And because of that, it has its weaknesses. So, and it comes from the Heritage Foundation originally. So there's an event in the future. If any of you guys are interested, you can email me. I'll get you on the email list. Talk about healthcare economics, if Medicare for all, what it would be in the United States. So anyway, anyone have any questions? All right.
Those people who are live streaming, let Mary Kendall know at mkendall2@kumc.edu. So, did you answer her question before? I'm not sure you did.
Yeah, monopoly buying, the prices are high because we don't have monopoly buying power. Basically, we don't negotiate prices. So prices should be high in a monopoly. So you respond to that by negotiating prices. So that's why the prices are still high.
So really, is that more on the hospital that are actually saying you have to pay this price?
I mean, if you were a car salesman and you could charge $100,000 and get it for a car, it's more on the fact that there's no countervailing force. There's no negotiator on the other side. It's fragmented between hospitals and doctors and whatnots.
Any other questions? The surgeons have 4 questions. So, come on.
Well, I'm a surgeon, so.
Oh, gosh.
I have another question.
All right, go ahead.
Sure.
Of all of this stuff, and this might be too simplistic, tomorrow you could snap your fingers and like one thing about our health care system change that would have the biggest ROI, what would it be in terms of?
So the question is, what would be the most efficient healthcare system tomorrow for the U.S.?
I mean, because we talk about all these changes, the government system, private.
Yeah. So spending per capita in the British model is the cheapest, but given the United States' actual experience with the VA, I don't think I could recommend that, even though that actually is the cheapest. So I do think practically Medicare single payer system makes the most sense for this country right now. Even though it costs a little bit more than.
I knew you were going to say that, but and maybe that's the answer you're looking for, which one do you prefer, but I thought you were also asking if you weren't making a wholesale change, and if you could tweak one thing in our current system.
I don't know. I don't know that you could change one. That's a tough one. I think it's inarguable prescription drug prices should be negotiated. I mean,
yeah. That makes sense.
Yeah.
Good one. Any other questions?
Oh, yes, in the back.
Yeah.
How doctors wish.
Repeat that?
She's talking about the cost of medical education.
Implying because our medical education costs more, that we need a healthcare system where we can make more to pay for it.
Yeah. It's an interesting question. You get that. Yes, medical education should be significantly cheaper. I mean, I was lucky. I went to UTMB. It was like $10,000 a year. I was the cheapest med school in the country. So, I mean, I agree. Medical education should be cheaper. Are doctors looking at that to have higher payments? I don't know that there's any one-to-one ratio that doctors get paid more as the medical debt goes up. I don't think those are linked at all. I think we should have free or nearly free medical education. I think it may affect your specialty choice if you have higher debt levels. I think that's more of the impact than the reimbursement. I had another thought.
You're right, though.
Yeah. Oh, the other thing is actually how doctors became rich in the United States actually is pretty interesting. I don't know if anyone would be old enough to remember. I had a program director who was, or his dad was. Doctors actually didn't make that much money in the United States before Medicare. They were making like the equivalent of like $80,000 in today's money before Medicare. And doctors became rich apparently under Medicare, because when Medicare was first created in '65, there was no price controls at all. There was no DRGs, there was no billing. You just billed your usual and customary fee. So doctors just wrote the bill for whatever they wanted. So doctors became rich actually over Medicare. So if that might have more to do with why physicians are paid more than actually the debt, because that's the origins of it. And it's just been sort of stuck that way for 20 years, 30 years.
So in general, what role of research funding and medical research funding do you think plays in terms of a country's ability to cover everyone? Because I know in the EU, they spend roughly like 45 to 60 billion total on medical research in all of Europe. And the United States in 2017 spent like 170 or 180 billion by itself on biomedical research.
I was going to ask that question too. I think maybe we're asking the same thing. If U.S. is #1 per capita on spending, was how much per year? 10?
Yeah, I don't know the number, but I know they spend the most.
No, but you said it's 10,000.
Oh, 10,000 per person.
But in that number is the number for biomedical research part of that, the NIH research?
I don't know. I would have to look at that, but it couldn't possibly be.
Or maybe something different.
It could be, but even still, how much could it possibly be per person? $200 per citizen? I doubt it's even that much. The issue about medical research you asked is very interesting, very complex. I could give a whole 1-hour lecture on that one. But the political economy of medical research is a complex topic. What we see in the United States, entire science funding for the United States began under World War II or during the Depression under under the NIH, which was created around World War II time. So the issue we have in medical research is that we fund basic discovery, but much less on health services research. Like, what is the best way to deliver health care? Okay, so I'll give you a simple example. Infant mortality rates in, say, Mississippi or the east side of Cleveland, okay, are very high. Apparently, in Alaska, I was talking to a physician who said the Alaskan health services came up because they're under the Indian Health Service, which is like a VA type healthcare system. They came up with a way using healthcare extenders, using women in this village who would then notify a woman in this village, who would notify a nurse's aide, who would notify a nurse, who would notify maybe an NP, who would then notify a doctor. Using that method of alerting people, you're able to reduce infant mortality. So again, how do you research delivery? I don't think we do that at all. Furthermore, there's no, because the way our healthcare system is funded that way, there's no way to implement that. We could have some of the best ideas invented here. They're not going to be implemented in Mississippi. They're not going to be implemented in rural Missouri or the east side of Cleveland, because what's the motivation to do that? It's not a healthcare system. It's a health insurance system.
There's an attempt at that with the Patient-Centered Outcome Research Institute recording, which was part of the Obama Care Act. And I mean, that is an attempt to look at some of these things, but the fear is that's going to go away when the legislation.
I think they zeroed it out this year.
Well, it's supposed to sunset in 2018, and we'll see what happens with the next Congress. I mean, it could be reinitiated, but unlikely.
Yeah, I mean, those are interesting fields of research.
Maybe that's the last one.
All right.
So what is your take on the Amazon, JP Morgan potential healthcare venture to reduce costs for their employees?
Yeah. So I wrote an editorial to the Star. They didn't publish it. It's nonsense. So Atul Gawande, the guy who writes for the New Yorker, the surgeon, he got together with Warren Buffett, Chase Bank, and Amazon to reduce healthcare costs. I'm highly, highly skeptical because what I've showed here. Okay, say Warren Buffett owns the railroad, he owns BNSF, okay, for example. I mean, his workers are distributed all throughout the country. Okay, how is he going to negotiate drug prices all throughout the country? It's not possible. The only way a private sector can reduce healthcare things is if you have a closed system like the Kaiser Health System in California, which originally was created for Kaiser Steel's employees. So and you have to have a critical mass of people to do that. So the Kaiser, when they came to Cleveland, they were relying on auto workers and steel workers. As those jobs fell apart, Kaiser Insurance became less popular and it sort of fell apart because they didn't have the means of production, which is they didn't own Kaiser in California owns the hospital, owns the doctors, owns the insurance. It combines everything. There you could, but there's no way those companies, which are distributed throughout the country, could do that, because I don't think they'll form a critical mass anywhere. I think you're going to see there might be some like common sense reforms you can do. Maybe they're overpaying for this or that. You can make some tweaks, but I don't think you're really going to see anything sustainable because you can't negotiate prices. And you can't negotiate with all these hospitals because I doubt his employees are going to be a big enough chunk of any town. And then Atul Gawande in general, that guy doesn't know what he's talking about. He's working at one of the most corrupt institutions in the country, which has been indicted for price fixing the Mass General and Partners Healthcare. Their merger, actually, if you've seen Spotlight, the movie about the child abuse in Boston, they had a Spotlight a year or two before that, which is about price fixing in Mass General, which merged with Brigham and Women's, became the biggest healthcare institution in Eastern Massachusetts, and they control everything. They bully the insurance company. So I mean, he's got to look where he gets his paycheck from before he talks about healthcare reform.
One last question.
Sorry, so along those lines, with being more healthcare systems rather than hospitals, and different healthcare systems owning different hospitals across the country, do you see any of that either way, either them fixing the pricing in, affecting in a negative way, or fixing it up to fix it in a positive way, that they, like the Kaiser system, but nationwide?
Yeah, they're doing it, but it's to inflate costs. Yeah, it is the other direction. So the Cleveland Clinic, I was in Ohio for a few years, and they're buying up all the regional hospitals, they're buying up all the physician practices, and then they're like, well, look, we covered this. Same thing as Mass General did in Massachusetts. They were like, they're so big now that they can bully the insurance company. So that's what they're happening. And my wife was in Pittsburgh. UPMC is another beast that they created their own insurance company. Okay, so you're going to see, so the one sentence about healthcare economics is healthcare is the meal ordered by one person, eaten by another, paid for by another. So the doctor orders it, the patient uses it, and your insurance pays for it. That's anywhere in the country. So what's going to happen is these hospitals will buy all these practices and just increase prices. It's not, I mean, it's not going to really lead to lower costs.
Optimistic note, Dr. Bhat. I think the department has said he's available if he wants to come to your department. He'll make arrangements to do that. And I think we may do the R&D grant rounds and resident combined things. Because we come up with a big topic for the residents, we may do it again. Hey, how you doing? Good to see you again.
Say hi. I just wanted to know about a guy who is an oncologist. Wanted to open up his